we got pretty much all the way through the calcaneus. We didn't really do ankle though, did we? Did we do ankle last week? Okay, we did ankle last week. Okay.
Yeah, we did all that.
So I added a couple of things. Just I think we took a look at that one. External fixators are things that sometimes you run into. Sometimes there's just not enough of, like fracture is so severe that the area that needs to heal will just be so demolished that placing screws just won't do it. There's not enough to bite onto, right? So common Judet fracture is pretty common for external fixators, and what it is kind of like an exoskeleton. Everybody seen an external fixator? Anybody not? Okay. So the interesting thing about the X-Fix is, it's got a lot of metal in it, so it's going to show up on the X-rays, but at the same time, these rods are carbon fiber, and they're just like the X-ray tabletop. X-rays go right through them. They feel like they're metal, but they're not. Carbon fiber. The connectors and the pins, though, are metal, and they're going to show up pretty dramatically. So we're not going to spend just a whole lot of time on leg because the evaluation of leg distally is going to be a lot like the evaluation of the ankle. The evaluation of the leg proximally is going to be a lot like the evaluation of the knee. But there are some things we need to talk about. Very common in my career, my experience, most common place that you're going to run into compound fractures are in the tib fib. All right, so if you have a patient that's in the ER, even if the patient appears to be clean, I'd recommend wearing gloves because if they had a compound fracture, or even if you can still see the compound fracture, what you might run into is sometimes there'll be blood underneath the patient. And they've cleaned up all around them, but they can't really pick up the leg and clean up under the leg, or they don't really want to because you can reduce the fracture. Right, so you pick up the leg, and what happens is that the bone slips back inside of the skin, and it brings with it all the bacteria that may be on that bone. Right, so they don't want that to happen. So they don't want to pick up the leg any more than what they have to. So they'll clean up all the way around it, but they don't clean the under the patient's leg. So if you get in there and you're trying to assess what you're going to do. There may be blood under the leg. There may be blood under the backboard even. So make sure you put your gloves on. Otherwise, you're going to in some cases, take an exposure. Also, if you do have to pick up any kind of lower extremity, make sure that you support proximal and distal. If you've got a broken tib fib, a potential broken tib fib, make sure that you pick up proximal and distal so that you don't manipulate the fracture. That's even if you have a patient that doesn't have a compound fracture. Also, understand that the evaluation, if they've got a fracture in the lower leg, you're most likely going to be shooting an AP of the knee and a lateral of the foot, and then your next view is going to be in maybe a cross table AP of the foot with a lateral of the knee. You're not going to grab the patient's foot and make an AP of both ends. So just shoot it as it is. So really that's most of what you need to know about the leg, along with, you got to have enough image receptor to include about 1.5 inches past the knee and past the ankle. And we'll take a look at an x-ray here in a minute that they didn't do that. Because of the divergence of the central ray, you're going to project if you don't have plenty of image receptor, you're going to project it off the image receptor. If somebody's very tall, that may mean that you have to take your 17 by 17 image receptor and shoot them on their catty corner from one corner to the other, just to make sure that you've got plenty of distance. Right? So anode heel effect may play a part if you've got somebody with very thick, like thick knee and thick proximal end. You would put the anode over the ankle, and small focal spot if at all possible. So again, we're just going to skip through that. We're going to take a look at the images. So what we're going to talk about in the knee is an awful lot of the knee evaluation is going to have to do with the the head of the fibula. Okay, so it sits on the lateral side and kind of posterior to the tibia. There's going to be some superimposition on both the AP and the lateral. Just can't get around it. Because of its position, you're going to have a little bit of superimposition on both of them. Yeah. So expect a little bit of superimposition, but also when we get into the knee, the position of the fibula as it relates to the tibial plateau plays a part as well in assessment of your assessment of your angulation. So we're going to take a look at that here in a bit. So you want to see from, you know, the distal portion of the femur to below the ankle joint, portion of the foot. On the lateral, again, you've got superimposition on proximal and distal end both. Right. So here, what we've got is what I was referring to before. Collimated field or image receptor just wasn't long enough. Our placement of the anatomy on the image receptor was inaccurate, most likely. So, you know, we can move this patient up just a little bit and make sure that we include that. But very common, probably, I would say on the distal end, more common to clip than on the proximal end. And I don't know why that is. But this is a fairly young patient. You can still see some, you know, vague signs of epiphyseal plates. So common fractures, tib fib, you've got a lot of them. They could be mid-shaft, they could be distal, they could be proximal at the tibial plateau, and we'll take a look at each one of those. And the damaging thing, or the dangerous thing about them, is that very often you've got those spiral fractures, bayonet fractures, and you can cause more damage with those, right? So you've got some major arteries that travel down the backside of the leg, so you can cut one of those open with that sharp stop. So you've got to be really careful with them and not manipulate the fracture and potentially, you know, stab that into something vital. So then we get into the knee, and we're going to take a look at some fractures of the proximal end here in a minute when we get into the knee. So usually requires a grid. Remember, for grid use, there are two rules for grid use: over 70 kVp or 10 centimeters, which is on adults, a good size adult, shoulder size or knee size pretty much. So if you have a pediatric patient, you know, we tend to get locked into the mindset that we've got to have a grid on knees, but you don't, right? If you have a pediatric knee, it doesn't satisfy either one of those. So, you know, you've got a 6-year-old knee, you don't need a grid. But if you have a full-size adult, then you're most likely going to need a grid. So if you're phototiming, you need to collimate real tightly. You've got a pretty good sized joint space that you're going to put right in the middle of your image receptor. So you're not going to have bone over a significant portion, or a fair amount. I'm not going to say significant portion, but a fair amount of your photocell. So naturally, in some cases, if you leave your collimation open, you know, if you don't collimate in tightly, then between the scatter and the penetration straight to that joint space, sometimes your photocells send a signal over your timer circuit to discontinue your exposure a little bit prematurely. So first off, you want to collimate in tightly. You might even consider using a +1. Again, sometimes we also get into the mindset that we need to go up for a lateral, right? So an awful lot of what we did early on with the chest x-ray, you go from PA to a lateral chest, you need to increase. You go from a PA to a lateral wrist, you need to increase. PA to a lateral hand, increase. When you get to your knee, it's slightly less thick laterally than what it is AP. So, and it's also a little bit more difficult to get centered directly over the photocell, because when you do a knee, you're supposed to put a little bit of a bend in the knee, right? So where you use a +1 for the AP, you might consider hitting the lateral with a +2 if you're phototiming, or back off just insignificantly to like a 4. That's only a 20% decrease for the lateral. So for the AP, you want your femoral condyles parallel to the image receptor. Your central ray to just below the bottom, which is the apex of the patella. You know, we have a tendency to think apex as being the top of the mountain, but it's the bottom of the knee. So our angle for body habitus would be our asthenic. We'd ankle caudad, and that's really because of the tibial plateau is in its natural lay. It's in a little bit of a decline, right? So what happens is we've got our tibial plateau, like, say foot's down there, in a little bit of a decline, but what happens is, as you know, that's with an asthenic patient, and then whenever you get to a asthenic patient, it's more perpendicular to the image receptor. And then you get to a hypersthenic patient, it's a little bit of a decline, right? So what we need to do is we need to angle our central ray 5 degrees caudad, and we're going to take a look at what if we don't here in a bit, but 5 degrees caudad for a asthenic patient, 5 degrees cephalad for a hypersthenic patient, perpendicular, no angulation at all for a sthenic patient. So what you need to really kind of remember are the size differences between those. So with sthenic patient, you know, you're looking at about 24 centimeters. Below that, you know, 19 to 24, you're going to angle caudad, and then much above that, we're going to angle cephalad. So hypersthenic patient cephalad, asthenic patient caudad. Yep, didn't really need that. All right, so for AP evaluation, what we're going to look at are symmetry. You know, do we have rotation? The tibial plateau, does it appear flat? Sometimes if you're over or under angled, the tibial plateau won't appear flat, it'll kind of appear wavy. And that usually is when your angulation is too caudal. So we'll take a look at that here in a minute. So, but as far as rotation goes, what we want to look at is the head of the fibula. Remember that we've got a little bit of superimposition on the AP on proximal and distal end, right, of the leg. So on the proximal end, we've got a little bit of superimposition between the tibia and the fibula, but you kind of work this out on yourself. You got your fibula over on this side, and tibia here. Fibula is kind of coming in the back. So as you rotate towards, it's going to tuck it up under more, right? So external rotation, you're going to get an increase in that superimposition, as opposed to internal rotation, you're going to get a decrease in the superimposition. Some hospitals call for a 4-view knee, and both of your obliques are going to be at a 45-degree angle, and that's what you're going to get, is a tucking of the fibula under the tibia, and then we get a, you know, the patella projected out and away from the center. Now, we have a tendency also to want to look at the patella and say, okay, well, where's patella centered? Patella should be right in the middle of the knee. That is not a good measure. It's kind of like using the toenail on the toes. It's just not a good measure, because you've got some pathology depending on the quadricep strength, really. You may have some tracking issues with the patella, and it might not track straight up and down where it's supposed to go. So in those patients, in a lot of cases, the patella may be off to the side a little bit further. It's not going to be centered naturally over the distal femur. Okay, so it's going to be a little bit off. As a matter of fact, you can see that on this. This is the edge of the patella here. So it's not centered. It's a pretty good knee. It's not perfect, but it's a pretty good knee, but it's kind of off to the side a little bit. So this was external rotation, and then this is internal rotation, and it's in the book as if this is really the completely accurate 45-degree internal oblique, and I think it's a little bit under oblique. That's just my personal opinion. I prefer to see my fibular head without any kind of superimposition over the tibia. So we don't see that joint space in its entirety. I think that if the patient was rotated a little bit more, first off, we'd start to see the patella off on the medial side a little bit, but we would also see that joint space a little bit better than what we see there. So again, external oblique, we're going to get an increase in superimposition on the tibial head. That's external oblique. Internal oblique, we're going to see separation between them. I've worked in a hospital. I've never worked in a hospital where a routine knee was a 4-view knee, but I have worked in a hospital where a routine knee was 3-view. And invariably, it's been AP, internal oblique, and lateral, okay? Never worked anywhere that the external oblique was a routine view. I think, though, that one of our clinical sites, at least they used to do a 4-view knee on a routine basis. So if that's hospital protocol, just, you know, make sure you follow hospital protocol. So as far as angulation goes, though, there are telltale signs that we can see, you know, and let's actually start with excessive angulation. All right, so a couple of things are going to happen with angulation. Okay, so you can see that you can see the posterior and the anterior portions of the tibial plateau separate from each other. But look how high the patella is. And now consider your anatomy. You're shooting AP, and what's closest to the image receptor moves the least, right? So what's closest to the image receptor is going to be your fibula, the head of the fibula, because it's posterior to the tibia. But then what you've got is the distal femur and the tibia, and what's furthest away from the image receptor is going to be the patella. So this moves the most, these move next to the most, and this moves the least, right? So what you've got over here in the fibular head, you see how high the fibular head comes. It doesn't come all the way up to the tibial plateau, but it's pretty high, right? But over here, it appears a little bit lower, right? And the patella seems to be awfully high. So what we've got there is a cephalic angulation that's too great. So maybe what we've got here is, it doesn't really look like an asthenic patient, but it may be a sthenic patient, and they utilized a 5-degree cephalic angulation. So what that did is it projected the tibia higher, and then it projected the patella even higher still. So then if we look over here, look how close the head of the fibula is to the tibial plateau. So again, thinking about anatomy, what we've got here is either a hypersthenic patient that needed an angulation or a sthenic patient that they angled caudally on. So what we've got is the tibial plateau is projected lower, and then the patella, we really can't see the patella all that well, but if this is the top of it, I would say the bottom is pretty close to here, which puts it almost into the joint space. Okay? Can you kind of see that? Again, your tibial plateau is not flat. It's kind of, got that rounded appearance to it. And then the easiest thing to look at is, where is the fibular head? If it's close to the tibial plateau, your angulation wasn't enough. If it's too far from the tibial plateau, then you've over-angled. Okay? All right, so lateral knee, remember that you've got 3 different angulations for AP, but for lateral knee, everybody gets 5-degree cephalic angulation. And the reason for that is because with the patient upright, your femoral condyles are pretty much parallel to each other. But the natural lay of the femur, the natural direction of the femur, is that with the patient upright, the femur, it's not completely perpendicular to the floor, right? So it kind of comes in just a little bit. We're a little bit knock-kneed, so to speak, which takes make sure I don't get this wrong, it takes the lateral condyle and projects it or pushes it a little bit lower than the medial condyle. All right, so once we put the patient on their side, what happens is we've got, put the patient on their side, I think I just said that backwards. The medial condyle is distal to the lateral condyle. So if we make an x-ray with the femur parallel to the image receptor, what that does is we've got our condyles. Our medial condyle is going to be distal to our lateral condyle. So what we need is a cephalic angulation to put them back on top of each other. Can you kind of see that? So everybody gets a 5-degree cephalic angulation on the lateral of the knee. Also, what we're going to have is a bend in the knee that's 15 to 20 degrees. And the purpose for that is to, and you'll see this in test questions, maximize the volumization of the femoro-patellar joint space. So big words just to say that the space in between the patella and the femur should be open. Okay, so if you bend more than that, what happens is you got the femur and the patella comes right down on top of it, pretty much is what it looks like. So, and we've got that's a good lateral knee. See the joint space is open. That's almost a perfect lateral knee. You don't see any real separation of the condyles. You see a little bit of a shadow up there, but it's a great knee. So overflexed, you see what happens here. It's still an almost perfect knee. You've got a little bit of separation of the condyles, anterior to posterior, superior to inferior. You don't really see it, but you've got the joint space is closed here. Okay, so that's what happens when you overbend your knee. Okay, that's just an accessory bone back there is all that is. So again, what we're going to look for in rotation is the fibular head, and where is the fibular head? So this is rotation. This patient's not perfectly lateral. They're rotated, and we see separation of the femoral condyles anterior to posterior. All right, so in our lateral, with our lateral, I've got the tibia over there, so if I like this, make sure I've got both the proper tibia and fibula. There we go. All right, so you see the superimposition, right? And I'm going to exaggerate this a little bit because of the divergence of the light. I need to. So you can see the fibular head right there, right? So with internal rotation, what we're going to see is desuperimposition, right? With external rotation, it's going to increase superimposition. So looking at these, what we see, that was on AP. On lateral, though, you're going to see the same thing. On the lateral, you're going to have, if the patient's rotated towards the image receptor, you're going to see desuperimposition. Can everybody see that, or am I in the way? And if you're rotated away from the image receptor, if your patella is rotated away from the image receptor, it's going to increase superimposition. Okay? So again, it's all about where is the head of the fibula. Is it tucked further underneath? And if so, your patient is rotated towards AP. I just said that backwards again. No, I didn't. So it's rotated more towards AP. It's internally rotated, as opposed to if you see desuperimposition, it's going to be externally rotated. The patella is going to be rotated more towards the image receptor. Okay? So that's the easy part. The harder part is if you have cephalic angulation. So inaccurate cephalic angulation, maybe the foot is elevated, you're shooting cross table, and you don't get completely perpendicular to the image receptor. Now what you're going to have is desuperimposition top to bottom, okay? So it's almost easier in this case because your condyles are fairly similar in height, size, right? So it's almost easier to take a look and see which one is magnified and go with that. So the more magnified one is going to be furthest away from the image receptor, so you shoot medial lateral. In a lot of cases, you can identify which one is which. The more magnified one is going to be your medial. If you're shooting cross table and it's lateral medial, then it's exactly the opposite. If you can see the abductor tubercle, that's going to be on your medial condyle, and they can give you some sort of indication as to which way you're tilted. Okay. So in a lot of cases, though, what you've got is just failure to angle. Maybe you're shooting a sthenic patient, you didn't angle for the AP, you roll the patient up for a lateral, you forgot to put your angulation on the central ray, and that's what you get. Or worse still, you've got an asthenic patient, you angle caudad, and then you roll the patient up for your lateral, and you leave that caudal angulation on there. It's going to be ugly. Okay. So common fractures, patella fracture. This is a patient that, you know, some of your patients, I think I talked about this when we were talking about humerus and the little girl that came in just moving her humerus all over the place. Some of your patients have a very high pain threshold, right? So, you know, and then some of your patients have no pain threshold at all. So you just don't know what patients you're going to have, right? So treat all your patients. If they complain about significant pain, they say they can't bend their knee, then assume they can't bend their knee. Don't try to talk them into doing something until you can get a good look at the one view that is least superimposed. We're going to take a look at that here in a minute. I forget who submitted it, but it was a knee with a nasty fracture in it, but the patient couldn't straighten their knee out. So in this case, you would want to take a look at this. You know, if the patient said, I can't straighten my knee out, well, just shoot your lateral the best you can and get a good look at the patella. And, you know, you don't want to bend the patient's knee if they potentially got a broken patella. So common arthritic changes are two things that we call valgus and varus. All right, so bow-leggedness or knock-kneed. And what we're doing with long leg images, where we take standing x-rays, and it may not even be with the long leg, you know, stitching software. It may just be AP with upright knees. What we're looking for in that patient is the patient in valgus or varus? And usually you can see that patient from, you know, just observing the angulation of the leg, but they need to do some measurements. And they used to have to actually use a tape measure, or not a tape measure, but like a yardstick, and physically make these calculations. We've got software now that does it for the doctor. But what they're trying to do is if they have to have a knee replacement, they're trying to take that back out of it, right? So if they're in varus, they're trying to get rid of the bow-leggedness. If they're in valgus, they're going to try to get rid of that knock-kneedness. And that's the purpose for doing those upright, is to see the joint space, but also make those measurements so that they can correct that anatomy on the patient. So that's what you usually see in the patient, is one of these two. This almost looks like that was the result of some sort of traumatic thing. Most of the time, your patients who have truly bad knees, that's what they look like. There's no joint space left. You got bone on bone, and you've got valgus or varus, one of the two. All right, so I've never had a patient with dislocated. Anybody seen that before? Just dislocated knee?
Not in the patient.
That's got to hurt, right? Total I don't see any fractures there. It's just dislocated knee. Patella's up there all by itself. That's gotta suck.
I've seen many a patella be pushed back.
Patella's pushed back? Oh yeah. So Osgood Schlatter's is a kind of a common childhood issue, where you've got this little, you know, it's almost like you got an epiphyseal plate there, and you've got some traumatic stuff going on right at that insertion. Tibial plateau fracture is pretty common. The dashboard slides back and just crushes the patient's knees. This thing is a mess. This thing's going to have maybe some bone grafts, probably external fixator. That's just nasty. So a lot of different ways that they fix tibial fractures, and we took a look at one earlier. But one way is to put a plate down the side of the tibia with screws going across it, kind of like what you see in the distal end, or really, this is very similar to what you're going to see in a hip nail. There may be a single big screw on the upper end, followed by a plate with littler screws going across. And then external fixation is always an option as well. Also, if if there's enough to screw into, again, back to this thing here, there's just not a whole lot there. We need to stabilize that, possibly put some pins into the fragments here, but there's just not a whole lot to drive a femoral rod through, or a tibial rod through, I'm sorry. So intramedullary rods are rods that go down through the medullary cavity. And what they do with those is they'll put the patient's knee bent at about a 45-degree angle and cut a hole in the upper portion of the anterior portion. It looks like it's going straight down through the tibial plateau, but it's not. It's going through the anterior portion, and then they have to hollow out the medullary cavity. So they have this long, first of all, they'll put a guide rod through it, make sure that they're all the way through to the ankle, and then they'll hollow it out, and then they'll drive that nail down through it over the guide rod. And these are, if you're squeamish, these are not the kind of procedures you want to be in on. These are bloodletting, okay? And it's so bad, and in most cases what they have is a vertical drape. So they bring in this, it's almost like a moving curtain, right? Or a frame. And they put this drape as a vertical drape that goes, I see some disgusted looks. Oh my God, this is just barbaric. It is, it's barbaric. But they put this drape over it to keep the sterile side of the room away from everything else. There'll be blood splatter all over the place in there. But it's very stable once they get it in there. They'll put a couple of screws that go through the bone and also through the rod to the opposite side of the bone on both proximal and distal end. And in that case, it just can't move, right? The whole inside of the bone is it's metal. So they can do that in both the tibia and the femur as well. Again, if you go to a surgery rotation, they say we're doing an IM rod. I hope you had your breakfast. And also, if you're ever in surgery and somebody looks at you and says, you need to sit down, don't say I'm okay. Just sit down because you're going down either way because you've already turned white. You probably started sweating. You're in denial. You're halfway to the floor already. Find a stool or at least back up against a wall because you're about to hit the floor. Okay? So this is, and you never know when it's going to happen. Most of my career was surgery and ER. And I'd worked in surgery for years and nothing really got to me. And I actually felt it one day. I walked into the room and it wasn't even my case. I was talking to one of the other techs and the doctor was putting pins in the patient's thumb. And the thumb was almost amputated, is what they call an amputation. It's not really amputated. The skin was still holding on. The guy, I'm sure, lost use of his thumb. There's nerve damage and everything else, but I almost went to the floor on that case. I mean, I've done dozens of these things. No problems. A thumb almost put me on the floor. So recognize that, if it's cold, it's always cold in OR, right? So if all of a sudden you find yourself sweating, you're in trouble, right? Or somebody looks at you and say, you okay? You're not okay. If they ask you if you're okay, you are not okay. So, but these will do it to you. Okay. So once we get to the femur, definitely you're going to need a grid unless it's on a very small pediatric patient. Your technique, again, column 8, use +1. So when you shoot your lateral, so the AP is pretty easy to phototime. Lateral becomes more difficult. You roll the patient up on their side, and the cross section of the thigh appears much thicker than what it was on the AP, right? So it's kind of hard to find bone and all that. Plus, once you get the patient up on their side, they're usually going across the table in some orientation. It's a little bit harder to phototime on the lateral, but your technique for the AP and lateral should be about the same. So set your technique for the lateral, if at all possible. Anode heel effect can still apply. If the patient doesn't have a fracture, you want to internally rotate the toes 10, 15 degrees. And the purpose for that is with the leg, the distal portion of the femur, AP, as you would have it for a knee, then what you've got is an angulation on the proximal end. So in order to visualize proximal end, you've got to internally rotate the toes. Some words you may see all the way through the registry is what we're trying to do is we're trying to put with that internal rotation is we're trying to put the humeral neck, femoral neck, parallel to the image receptor, right? So internally rotating the toes does that for us, but there's a word that they use specifically for the femoral neck, and that is anteversion. Okay, so you may see a question that says something to the effect of why do we internally rotate the toes for the hip or the AP of the proximal femur? And that is to overcome the anteversion of the femoral neck. Okay, you're not going to see the anteversion used for anything except for the femoral neck. At least I've never seen it used for anything with the femoral neck. So internally rotate the toes, and it puts the femoral neck parallel to the image receptor so that you don't get that foreshortening, and it overcomes the anteversion of the femoral neck. Okay? So that's if you want to see the proximal end. Back when we used to use screens of films, for every film that we used, it cost the hospital money. So, and wasn't all that much money. I think a 14 by 17 was under $3, but they would still just want us to shoot the AP for one end and the lateral for the other end. So usually what we would do is shoot the AP for the proximal end and the lateral for the distal end, because the lateral is much easier to get the distal end than what it is proximal end, right? So with proximal end, if you're doing a hip or a non-fractured femur, then what you're going to have to do is bend the patient's leg, externally rotate into a frog leg, and if the patient can get it parallel to the image receptor, you don't have any kind of foreshortening. But what that's going to require you to do is oblique the patient towards the image receptor in most cases, right? And then you might get into some issues with soft tissue overlap and the difficulty in determining where the head of the femur is and not clipping anatomy. So always easier to do the AP for the proximal end, lateral for the distal end. So if you're ever working in a hospital that they would let you do that, that's my recommendation. I've learned in recent years that most of your hospitals want AP at both ends. So you got to do AP of the proximal end, AP of the distal end. And what that's going to involve is positioning the distal end like a knee, right? So the condyle is going to be parallel to the image receptor, internally rotate for the proximal end. And then you do your surgical lateral, frog leg lateral, whatever it is that you have to do for the proximal end, and then maybe a cross table for the distal end, if the patient has a fracture. Also, though, that internal rotation, if the patient is suspected of having a fracture, you don't do that. Just feel obligated to tell you that. You should know that by this point. And there are telltale indicators that the patient has a fracture. So if they have a fracture of the hip, the most common thing is that they are going to have their that affected foot. They're going to have, it's going to be laying straight on its side, right? So you lay down in the bed on top of the sheets and you look down at your feet, and what do your feet look like? They're out to the side, but they're out to the side at an angle, most likely, right? So naturally, that's kind of, or you lay down on the floor, then your foot's about like that. So if you have a patient and their foot's all the way out to the side, that's a pretty good telltale indicator they got a broken hip, okay? The other weird, and this is weird, that's not weird, but this is weird. In most cases that I've seen, the patient will be leaning or laying more towards that hip, right? So they have a tendency to be oblique towards that hip. If they're oblique towards that hip and the foot is completely out laterally, just get an AP with the patient, whatever position they're in, and you can flatten them out a little bit, but don't try to get them to internally rotate the toes. Take a look at it, see if you see any kind of fracture, and then proceed for your lateral. Okay, I think I hit most of that. If not all of that. AP hip, same thing, 15, 20 degrees internal rotation. Oh yeah. All right, so if you go back into your Merrills, you look at the positioning for the AP of the hip, and what you see is that diagram where they've drawn a line from the ASIS down to the symphysis pubis, right? And then you go halfway up that line, and then at a 90-degree angle, you can find where the head of the humerus, keep saying humerus, head of the femur or the neck of the femur is, right? Well, first off, that requires you to palpate the symphysis pubis. We've covered that over and over again. Don't really recommend you do that. So you got to know that for the registry. You got to know it all the way through the registry, and sometimes your test question on that will say something to the effect that you draw a line from the ASIS down to the symphysis pubis, cut that line in half, and come off, at 90 degrees from that. But what it'll say is a line that bisects the line that is drawn from the ASIS to the symphysis pubis, and that's what they're talking about, is that diagram. So 1.5 inches down that line, you got the head, 2.5 inches down, you got the neck. But the easiest thing to do, positioning wise, is to forget all that. That's a test question, right? So forget all that, but put the top of your image receptor at the patient's ASIS, center that up, the ASIS, so you've got the two lines of collimation, one that goes that way and one that goes that way, and put the vertical line coming straight down the ASIS, and you're going to hit it every time. Never miss, right? So that's the easiest positioning wise. And if you're doing a femur, then you might want to position just a little bit higher than that, because you got the divergence of the central ray that might project it up a little bit higher and off of the image receptor. For the hip, ASIS is fine. And for the femur, you might go just, 1 inch above that, just to make sure that, the divergence of the central ray doesn't project it off. All right. Oh, that's ugly. Okay. So, let me get this off of here just real quick.
Just pull it up.
There we go. All right, so that's a frog leg. It worked, All right, so if you're having to do a frog leg, well, let's just get to Danelius Miller. Okay, so that's not quite as bad. So frog leg, is pretty straightforward positioning, but the surgical lateral is a little bit more difficult. Really what you're trying to do with the surgical lateral is to put the image receptor parallel to the head of the femur and the central ray perpendicular to it, right? So one thing that we have a tendency to do, or I've seen people try to do, is to put the image receptor just up against the hip like that, okay? Well, the femoral neck is coming off at an angle. So that's number one. Make sure that you put the femoral neck at an angle. Number two is I've seen people have a tendency to find the iliac crest and want to put it right at the iliac crest. You're almost always going to clip it at that point, okay? So what you need to do is go slightly above the iliac crest so it'll push into the soft tissue directly above the iliac crest, not on the iliac crest. So it come in a little bit further, okay? And then your central ray perpendicular to your image receptor. Now the thing that we, some of the positioning in this textbook that is probably less important than what it used to be because of our computer algorithm, but it could still affect your image, is the position of the opposite leg. So in a lot of cases, what we have a tendency to do, let's say we're shooting the left, is we have a tendency to just raise the right leg up, right? Get it up, 90 degrees or whatever. And the thing is as you elevate that leg, so you got your gluteus on both sides, right? And this one just kind of curls up like that, but it's still there, right? So if you externally rotate the unaffected leg, it takes it and it kind of puts it over here a little bit. Okay, gets it out of the way a little bit so that with the knee just bent at a 90-degree angle, you could project that opposite butt cheek onto the head of the femur, okay? So if you externally rotate it, it removes that as a likely possibility. So it still could affect your image, so I still recommend that you do it, even though it's probably not quite as vital as what it used to be with screens and films. Okay. All right, so types of hip fractures. Fundamentally, we've got two. One is, a third would be technically a proximal humerus fracture. There we go again. Femur fracture. All right, so you got your femoral head, and you've got the femoral neck, and then you've got the two trocaners. You've got the greater trochanter, and you've got the lesser trochanter, and you got a fracture, two hip fractures. One is the femoral neck, and one is what we call an intertrochanteric hip fracture. Okay, in my experience, intertrochanteric is probably the more common of the two, and you see your traditional hip nails with that. And by traditional hip nail, what I'm talking about is you've got screws going up into the head of the femur, and you got a plate that goes down the outside of the femur. Okay, we'll take a look at that here in just a second. So you got screw, plate, and more screws go through. There's a couple of different types of orientations for this we'll take a look at here in a minute. But and there's a video I posted for this one, but it's a femoral neck fracture. They'll do what we call percutaneous pinning or perc pinning. And what that involves is 3 screws that go just from the lateral portion of the femur all the way up into the head of the femur across that fracture line. Sometimes they use 4, but in my experience, most common orientation was 3. So from geometry, you know that a pyramid is like solid, right? Very, very solid. So triangular shapes tend to be very, very strong. So what they'll do is they'll take 3 screws and they'll put them in that orientation up into the patient's, from the lateral side, parallel to the neck, up into the head of the femur. I don't want to call it humerus again. But they'll put it in that orientation. So you got 3 of them going up like that, and they're parallel to each other. I can't make my fingers do that, but they're parallel to each other, and they go all the way up into it. So what you'll see, though, on the image, be it AP and lateral post-op on this patient, you may only see 2, because 2 of them may be superimposed. And then on the lateral, you may only see 2, or you may see 3 that look like they're parallel to each other, right? But that's a surgical neck fracture or femoral neck fracture. Intertrochanteric fracture is usually fixed with something like this. It's what we call a gamma nail. And it starts out like an IM rod, so it's got screws going through it, and then you've got that big screw going up into it. Or this one, where just this portion goes inside of the femur, and then they put this great big screw all the way up into the femur, and it locks this into place, and then you put screws through it, and it's pretty solid as well. So this is really pretty traditional. This is a newer technology, and by newer I mean since got out of clinical practice. So this may be 20 years old. I don't know. Newer. So other childhood injuries or issues that are relatively common. So what this involves is it's kind of like an avascular issue with the head of the femur. So temporarily or permanently they lose vascularization, and that leads to essentially the death of the head of the femur. In adults, we see that as well sometimes, and that's truly what we call is avascular necrosis. And with kids, you know, they've got hip pain for an extended period of time, and it's often not caught until it's too late. But in adults, again, hip pain, and what they'll do in a lot of cases is they'll take, it's kind of like a core sample. You know what a core sample is? You know, they want to see how old the ice is, so they drill a big hole into the ground, they pull it up, or, you know, if they're doing mineralization, try to figure out what minerals things are. They basically do that. So what they do is they start off kind of like a hip nail. They come out on the lateral side of the hip, and they take these things they're kind of like hollow drill bits. They run them up into the patient's hip, and all they're trying to do is take plugs of bone out of the patient's hip, hoping that, you know, they've got that bone that's so compact that blood vessels can't get through it, and the head of the femur is dying. So they're hoping that by punching some holes in it, it'll reestablish some blood flow. I don't know what the success rate on that is, but, you know, I've had surgeons say that it's kind of like a last-ditch effort to try to get vascularization back into it, and it almost never works. So there's that. So just if you want to see what a perk pinning looks like, there's a video there for that. Okay, so real quickly, and I've only got like 5 minutes, so we're gonna make this real quick. Judet views. So Judet views are, if you go back to your Merrills and you take a look at Judets, they're specific for unilateral hip, right? But you do bilateral. So you do, it's 45-degree bilateral hips. And it shows you the acetabulum. But the local radiologists don't like Merrill's positioning. What they want to see most of the time whenever you're shooting Judets is, first off, we're doing fractures, and most of the time it's post-op, or a lot of times it's post-op. If a patient has a pelvic fracture, they can be very, very unstable. I'll put some stuff in here about pelvic fractures too. And these are in Canvas. I replaced the old PowerPoints in Canvas. So what we see with Judet views is pretty much any fracture in the pelvis. In 2 views, you can diagnose all the different fractures in the pelvis. So looking at the pelvis and imagining what happens with the pelvis as we oblique, we've got this guy here, right? So if we oblique into LPO, like so, then what that does is it puts the pelvic wing on the side closest to the image receptor, parallel to the image receptor. So if the patient has what we call a vertical shear fracture through the pelvis, we can see without any kind of foreshortening or any kind of distortion the fracture of that iliac wing, possibly all the way down into the SI joints, possibly even into the sacrum. But it takes this one and puts it perpendicular, right? So the side that's elevated is perpendicular. So we can see an AP of the side closest to the image receptor. We can see a lateral of the side furthest from the image receptor. So if this side has a fracture, now we can see anterior to posterior displacement. Also looking at the anterior pelvic bones though, what we get is on the side that's elevated, it becomes more open, right? So the elevated side looks like this, is more open. Side closest to the image receptor becomes more vertical, so we get an AP of the elevated side and a lateral of the side closest to the image receptor. So we get AP of the iliac wing that's closest, an AP of the anterior pelvic bones and the obturator foramen that's furthest away from the image receptor. You get a lateral of the elevated iliac wing and a lateral of the anterior pelvic bones that are closest to the image receptor. At the same time, we get an AP and a lateral, of the acetabulum, which is what Judet called for this view to be, is an AP and a lateral of the acetabulum. Okay, so in 2 views, we can see the entire pelvis in 2, an AP and lateral. right? So this is what our local doctors like to see is not the collimated just for the acetabulum, but rather they want to see the entire pelvis in two views for the Judet views, okay? So just in a word, essentially, or two words, what do we do if the patient's so unstable you can't oblique the patient? Inlet and outlet views kind of give us the same thing. Not really of the pelvic wing, but of the anterior pelvic bones. With the outlet view, we've got that cephalic central ray angulation, puts our central ray perpendicular to the anterior pelvic bone so that we can see kind of a frontal view. And then we see an axial view, superior to inferior, with that caudal angulation of the anterior pelvic bones. Okay? Kind of gives us the same thing of the anterior pelvic bones, not so much the iliac wing, but if we've got some of these other fractures, that just looks awful, doesn't it? But if we've got some of these other fractures, then we can make a diagnosis of those with the inlet and outlet views. Okay, so I added these in, but we're really out of time. Sylvia gave us this one. This was the one I was talking about with the knee. If you've got a patient that comes to you and they're just bent to a degree that you wouldn't be able to make sense out of that, I would say shoot your least superimposed view first and look for a fracture, and maybe
that's what we did. We shot that one.
yeah. But you can see the fracture here. It's, you know, something looks weird here. You can see the fracture there. Certainly, you wouldn't want to, you know, force that patient to straighten that out. Jana gave me this one, and it's so small that it's kind of hard to see. But did he say that he did this himself?
Yeah, the nail gun. He was working and it accidentally went off.
Yeah. So kind of from the side, you know, you almost have to work at shooting yourself with a nail gun anymore, because there's a safety on the front of the nail gun.
Well, you gotta disable that.
Yeah,
Just
he put
like
it
you take
down.
over
Right.
skill saws, the first thing you do.
Well, that's what I was gonna say. Is you've got to disable that in order to have this happen, or you've got to go down. You know, but in my experience, the way people shoot themselves with a nail gun anymore is if they're cleaning up, they grab the gun and then they bump the safety on the front. By safety, what I mean is there's a thing on the front of the nail gun that you actually have to depress in order to shoot, right? So you either got to take that off or you got to bump it. But I've seen patients picking stuff up and they bump it and shoot themselves in the hand.
He was at work.
So